Okay, well, we are live. We are really excited to be with everyone today. We have really wonderful experts, medical experts in their field to discuss with us a lot of issues surrounding what so many people are talking about, which is the global pandemic, COVID-19. Uh, so, just as we begin to get started, I want to make sure everyone knows who we have on today. My name is Tom McNamara. I'm mayor of the city of Rockford. I am not a medical professional. So we went out and we made sure that we have two amazing individuals who are experts in their fields. We are fortunate to have Dr. Mike Polizzotto, who is the chief medical officer. We are also fortunate to have Dr. James Cole, who is surgeon in chief and trauma medical director. And as I was joking with them before we began today, I really need a new title because their titles are far fancier and probably far more well-deserved than mine. So again, thank you, Dr. Polizzotto and Dr. Cole, for joining us. Really hot topic right now, right? I want to say first and foremost, thank you to both of you. And thank you to both of your staffs and all of the healthcare professionals who are on the front lines, absolutely doing amazing work. They're tired, they're exhausted, and they continue to persevere to make sure that every single person who needs care gets it. So just want to say thank you to you both and your entire teams. But don't want to waste a lot of time. And I will tell both of you, we have a lot of questions for you. A lot of questions came in. So I would ask, I know you guys are far smarter than politicians, but politicians like to go on and on like I am right now. So I would say if you could synthesize your answers, and if we need to dive deeper into them, we can. But we have a lot of questions, probably 15, 25 questions we'd like to get through as quickly as possible.
Right.
Again, thank you. We now have about 30, 35 people joining us online. Appreciate you guys joining us. And again, we have Dr. Mike Polizzotto and Dr. James Cole with us today. So let's just start. What are your current numbers of hospitalized patients with COVID-19?
So those numbers change a lot over each day, but this morning at 7:30, we had 99 patients in the hospital here because of COVID-19. 22 of those patients were in the ICU, which is out of the 30 beds we have there, obviously the majority of our patients in the ICU right now.
Can I just ask a question? What does it mean that they're in the ICU? I think nowadays we're talking so much like we have this many patients in the ICU. What does that mean that patient has reached that level?
Well, Jim cares for some patients in the ICU. So why don't you answer that, Jim?
So, traditionally people that are in the ICU are the ones that are the sickest patients that require the closest and most frequent monitoring, require advanced therapies such as intubation or different kind of medications, drips, and so forth and so on that require very attentive, specialized nursing care. However, what it's really become during the COVID pandemic is the sickest of that particular cohort that I just described to you, because, and exclusively due to COVID and those COVID patients sort of filling a system that ordinarily didn't have COVID patients, a number of patients that ordinarily might have met that criteria are being managed now in intermediate care wards. So what that means is the people presently in our ICU are truly and unequivocally the very sickest of the sick in all of Rockford.
Wow, thank you. And I don't know if you would know this, but we have obviously, and now we're close to 60 folks following us today. And to those who are joining us, thank you. If you have questions or comments, you can pop them in the comment section. We'll try to get to them. We have already received a lot of questions, so we're trying to get through those. So doctors, I'm not sure if this is a fair question or not, but I think you mentioned there's 22 folks in the ICU that have COVID. Do you know how many patients are in the ICU that do not have COVID?
There's about 6 right now that don't have COVID, which means we have, again, this was an hour ago, 2 beds open. In a lot of cases, those beds are waiting somebody who's in an OR, for example, who will need to come into a critical care bed. So the vast majority of our patients in critical care right now are there because they have COVID.
Wow. So only 6 out of the 28 that are in the ICU are not there for COVID. A couple of questions. Of those that are actually in the ICU, do you by any chance know how many were vaccinated or not vaccinated?
So we keep track, not per day on vaccinations, but over the course of every week, we kind of look at a cumulative count of the number of patients that we've had admitted for COVID, because a patient can be here for, with COVID, they can be here for 30 or 40 days even. But as we look at that cumulative count that we started in August of this year, we know that 82% of the patients who are hospitalized with COVID here at Swedish American have not been vaccinated. So only 18% of all the patients who are here have been vaccinated. And then if we look at the patients who are in the ICU because of COVID, it's about 90% that have not been vaccinated. Only about 10%. It's actually most recently about 10 out of 94 of them that have been vaccinated. So it's another example of what we hear, what we read in the medical literature, and we hear just sort of generally COVID vaccines are very protective of the more severe forms of the disease. Even if you get COVID, you're less likely to get severely ill and end up in a hospital if you've been vaccinated.
Excellent, thank you. And since we're talking about vaccinated, can we be pretty clear and one of you define what is vaccinated?
Yeah, vaccinated is 2 doses of the mRNA vaccines or 1 dose of the J&J vaccine. We do talk about boosters, and anybody that has been 6 months out should be vaccinated, or should be boosted, but we don't yet consider people who have not been boosted. We don't exclude them from the fully vaccinated column. So if you've received the 2 doses of the mRNA or the 1 dose of the J&J and 2 weeks have passed, you're fully vaccinated by definition.
Okay. And we talked, I think in total you have 28 patients in the ICU. How does that compare to, let's say, 2-3 years ago prior to the pandemic? What's a regular number of patients that you would typically see in the ICU?
So we have 30 beds in the ICU. Routinely, there was a whole, what we call a pod or a section of the ICU of 6 beds that we just didn't even ever open. We never needed to use them. And so on busy days, there might be 20 people in there. Routinely, there might be more like 16, 17 people in there. It was highly unusual to have even 24 patients in the ICU. And certainly in this most recent surge, there really isn't a day where we haven't been pretty close to maxed out, very close to 30.
Okay, good information. Thank you. So we get this question a lot, that COVID really only touches the older folks in our community. So when the pandemic began, we heard a lot about that it's only impacting the older people in our community, and that all the younger people are just fine. They don't need to worry about anything. Is that still the case?
No, they need to worry. The younger people need to worry. It absolutely used to be mostly the older, frail patients that were most affected. But now there's only 1 patient in our ICU who's older than 70. Everybody else is younger than 65. And we have had patients in their 20s, 30s, 40s, 50s die of COVID recently. I mean, this is a real problem with the younger people. And maybe they have minimal comorbidities, but some people have no comorbidities and they are still getting very sick from COVID. These are unvaccinated younger people.
And just define, you mentioned comorbidities. Lots of people know what it is nowadays, but just define that so that anyone watching can understand.
So 50% of America is overweight by definition. So if you are overweight by definition, you have a comorbidity. If you take blood pressure medicine, you have a comorbidity. If your blood sugar is too high, you have a comorbidity. It's that simple.
Excellent. Thank you. And are you seeing over at Swedes, are you seeing patients who have had COVID, let's say once before, maybe several months ago, now getting it a second time? And if they get it a second time, do we know if it's worse or not?
So we don't see a lot of patients readmitted to the hospital with a second COVID infection, but I will tell you that it's not uncommon for patients who get an infection. They seem to be doing okay for several days. Maybe they're kind of hanging in there at home for even a couple weeks, and then their shortness of breath within a matter of hours or a day gets extremely bad, and they end up here, even 3 weeks after their initial diagnosis. That's not really a second case of COVID. That's, their initial infection. So in general, you don't, people can get a second case of COVID. When you have an infection, you decrease your risk of reinfection for about 6 to 9 months after that initial infection. But after that time, it appears that your risk of being reinfected gradually increases, probably to the point where you're just as likely to get it as anybody else. But we don't know that for sure yet. A second infection is usually milder than the first one, but there are reported cases in which it's more severe or even fatal with a second infection.
Okay, we've had some good questions, and I'll throw two out to see if I can get some answers here. And I should have asked this previously when we were talking about patients with comorbidities. Do all the patients in the ICU or that are being hospitalized, do they all have comorbidities?
No, they don't.
No. Okay, and then there was a good question here. We were talking, maybe it was you, Dr. Cole, who were saying that absolutely it's not just older people. You're seeing people 20s, 30s, 40s, 50s die from this. Why are we seeing younger people now more infected? Or were we always seeing it? I don't know.
So the younger people are the ones that are in the greatest percentage of the population that are unvaccinated. I mean, this is a pandemic largely of the unvaccinated. And this is the population of people that works and people that work around other people that essentially commune with other people on a regular basis rather than they're retired and they sort of isolate themselves, among one or two friends. So it's a younger, unimmunized group of people that continues to engage with everybody else that's unimmunized, that engages with other groups of people, and the virus just keeps spreading.
Thank you. So I know your answer to this, but I'm just going to ask it. Do you recommend patients get the vaccine? And that's one question. The second piece to that, as I'm laughing, is you often hear, make sure that you talk to your doctor before you go get anything really medical. Can you talk through that a little bit?
So I guess you're not going to get anything but strong, yes, absolutely get vaccinated answers to the question, do we recommend the vaccine? We absolutely do. Both Dr. Cole and I are vaccinated and have boosters, and pretty much everybody in our family that we can convince to do it is vaccinated in the same way. So in terms of talking to your doctor, it's always a good idea to have a conversation with a physician who knows you, knows your background, understands the illnesses that you've had, the injuries that you've had before you undertake any medical treatment. The vaccines are very, very safe. I don't think there are too many situations in which people would need to feel uncomfortable if they felt like, they haven't had it yet and they can't get a hold of their doctor and they want to get out. If you've had allergic reactions to vaccines, probably a good idea to talk to your doctor, but it probably doesn't mean you can't get it. Outside of that, I don't know. I think make a quick phone call to their office. I'm sure they will call you back quickly and say, yeah, you want to come in and get it, or go to Walgreens or whatever and get it done.
I'm going to be even stronger than that. My opinion is, unless you have had a severe anaphylactic allergic reaction to a vaccine, and it really should be to one of the components of an mRNA vaccine that's required you to go to the hospital and get epinephrine or something like that. If you're not in that category, you should just get vaccinated, because the safety profile of this vaccine, of the mRNA vaccines and the J&J, are very, very safe. And the risk of death from the vaccines are so minuscule it's almost not worth even talking about, but the risk of death from COVID is still about 1.5%, which means that the risk of dying from COVID is more than 1 million times greater than the risk of dying from a vaccine.
But
Yeah, so
Dr. Cole, if we didn't talk about things that are totally impossible, what else would we talk about on Facebook?
I'm sorry, I didn't understand the question.
I'm just joking. People like to talk about things on Facebook that have nothing of relevance, and you highlighted some very good reasons. So moving right along, and I'll try to stop being a smart aleck, is all right, we've heard a lot of people do get side effects from vaccine. What are those side effects, and how common are they?
So they're pretty common, but they're generally mild and last a day or two. So about 65% of people are going to have some swelling or soreness at the injection site. And anywhere from about a quarter to half of patients will experience some fatigue or generalized achiness. Fever occurs in about 20% of patients. These effects are more likely to occur if you receive the mRNA vaccine, one of the mRNA vaccines, with your second dose than with your first dose. But like I said, those are self-limited. They go away. You can take some Tylenol. They go away within a day or two. The more serious side effects, the two that are kind of talked about the most probably are the severe allergic reactions, life-threatening or allergic reactions, which happen about 5 out of 1 million times. So a risk of like 0.0005% of having a severe allergic reaction. And then also the inflammation of the heart, myocarditis or pericarditis, which is generally in a younger person, and I'm saying younger here, under 45. And that occurs about 16 out of 1 million patients, or 0.0016% of the time. So again, just reinforcing what Jim was saying, which is that there are some risks to the vaccine. In most cases, they're really about mild side effects in the first couple of days. And the more severe risks are 1 million times less likely than dying of COVID.
And let me actually just say, Dr. Polizzotto mentioned about myocarditis. It's 8 times more likely in people who are unvaccinated and who had COVID compared to those who just get vaccinated. So it's a win-win situation. Get vaccinated.
Perfect. Thank you. So some people have said that, well, I've had COVID. Now I know I don't need to get vaccinated. Is that true? If you've had COVID, do you not need the vaccine?
That would be unwise, because the original strain of COVID, we'll just call that wild type COVID, has gone through several variations, several mutations. And these are the people that are getting COVID a second time because their, quote, natural immunity is waning, and these new variations, these new mutations are evolving, and people are susceptible to COVID once again.
Okay, I think we're beating this to death, but are there other myths that you want to get out regarding the vaccine?
If you don't mind, I would love to talk about this, but I'm not going to talk about the myths in specific. I could talk for hours on the myths, okay, and dispelling the disinformation. But what I do want to talk about are the people that have sort of subscribed to this disinformation campaign. And it's possible that if you are among this group of people that really is anti-vaccine or COVID vaccine, or doesn't believe COVID's as serious as it is, like, you may be among a group of people that has been unfortunately just sort of lured in by people who are using very damaging psychological tactics, almost cult-like tactics, to get you into this cult-like mode of thinking that somehow we're trying to do something bad to you, or that COVID's not as bad as it is. And, I talked to a number of people trying to really help them, to really understand the realities of COVID and the vaccine. And they all tell me, oh, I've done my research. And I'm like, what, do you have a lab in your basement with petri dishes of human culture and microscopes? And they're like, no, I've read stuff on the internet. And I tell them, reading stuff on the internet may be okay for a junior high term paper, but it's not considered research by our standards. And we're talking COVID, virology, immunology, critical care. And the only real way to learn the truth of COVID and what the realities are happening in the sickest of sick people, the only way to know that is to talk to the people that have actually cared for these people, the specialists in the ER and the ICU that treat these patients in the hospital. That's how you can really find the truth of all these conditions. So I just urge people to go to the right source for the information.
The only thing I would add to that is that, I know that there's a lot of voices out there, and sometimes that can be kind of confusing to figure out and difficult maybe to decide who you're going to trust. But I would ask those of you who are listening to think about, what is your plan if you break your leg, or you have a heart attack, or you can't breathe, or you have symptoms of a stroke? Do you plan to call 911 and come to a hospital? Because if you do, you are trusting medical science to take care of you. And so if you're going to be willing to trust medical science, then trust it now and get vaccinated.
I just want to say amen. So a couple of quick things, this will be two questions, I guess. Can someone get the COVID vaccine and the flu vaccine at the same time? What's your recommendation around that? And the second piece of this question is one of these myths, we'll say, or I think, I'll let you determine if it's a myth. Is COVID, I can't believe we're still asking these same damn questions, but is COVID the same as the flu?
So I'll take that second part. No, COVID is not the same as the flu. I am not a virus specialist, but I did get enough information in a class in medical school to know that there's just as many families of viruses as there are of bacteria or types of horses or any of those other kinds of things. And the COVID virus as a coronavirus is very different from an influenza virus. And the diseases they cause are, although the symptoms initially in some cases look a lot alike, maybe, the diseases are very different diseases. And in terms of the vaccine, yeah, you can get a COVID vaccine and a flu vaccine on the same day. In fact, the COVID vaccine can be given with, I don't think there's any vaccine you can't combine with the COVID vaccine safely. So if somebody's due for their flu vaccine, in fact, if you haven't had a flu vaccine, I would definitely get a flu vaccine this year too. And if you haven't had the COVID, just get them at the same time.
Yeah, and as I said on another recent interview, more people have died from COVID-19 infection in the last 12 months than have died of influenza infection in the last 12 years. So they're very different.
Can you repeat that just so everyone at home can hear it again?
More people have died of COVID-19 infections in the last 12 months than have died of influenza infection in the last 12 years. Okay,
Perfect.
so they're very different. In the United States, we have the lion's share of COVID around the world. We have so much COVID in the United States. And, a country like India, that's number 2, that has 1 million more people than us, they have half the COVID cases. I mean, we are just not doing a good job of preventing the spread of this virus by getting vaccinated.
Thank you. So there are a group of people in our community and across the country and I guess the world who will never get a vaccine, or never get the COVID vaccine. So let's put them aside for a second. Those who are genuinely on the fence, it was rushed. The politics of it, the information, how it came out, all of that. What do you say to those who genuinely are just a little hesitant and want some additional information? What do you say as experts in the medical field about getting that vaccine to talk to someone who may be on that fence?
Well, the vaccine's been out, right? And we've been using it now for a very long time. There are so many documented cases of vaccine administration. We really have the data, so we know it's safe. And what we don't have is the long-term data with respect to what the aftermath is from all these people that got COVID. We know already that up to 5% of people have long COVID, possibly more than that. Neurocognitive issues, cardiopulmonary issues, We're going to have renal issues long term. And so I would strongly advise taking the vaccine rather than taking the risk of getting COVID and developing long COVID.
Okay, thank you. Another thing that we hear very frequently is 99.9% of people who get COVID survive. What do we say to those people? One, is that accurate? Two, what do we say to those people? Because they say this is a very low risk that they have, and they just want to live their life. They want their freedom and don't want to wear a mask and don't want any mandates to get a vaccine.
Yeah, so first of all, I would say you're not too far off on the rate of death. It's probably, Dr. Cole, I think, mentioned earlier, it's probably in the range of 1.5%. So it's hard to know this exactly, and it kind of depends on when you start measuring it, at the beginning of the pandemic or in the last few months, but it's probably somewhere between 97 and 99% of people who survive COVID. But surviving COVID it's not just, did you live? I mean, did you live through it, right? Because there's a lot of people that we talked about who are in the ICU. When you've been on a ventilator for 30 days or even 2 weeks, that is weeks of rehabilitation to get your strength back. You lose all kinds of muscle mass. There's, in many cases, permanent damage to your lungs. So it's not just survival in terms of not dying from COVID, it's the implications. And then there's this whole thing that we don't understand very well yet called long COVID, the people who somehow are having symptoms that are ongoing after they get over the initial infection. We don't really understand that very well yet. That's a whole nother range of disability that could be associated with being infected from COVID. So it's not just whether or not you're going to die. It's also the potential to have to live with some of these long-term consequences. Now, having said that, I don't think anyone should be living in fear. I don't think anyone should be saying, oh, I have to shut myself in my house and never come out, and COVID has, means that I can't live a normal life. If you're vaccinated, if you're taking precautions in terms of wearing masks in public places, especially indoors, if you're doing your best to avoid things like going to work when you're sick so you don't expose other people and you get a COVID test first, and other people in your workplace and your family are doing similar kinds of things, then there are a lot of things we do in life that come with some risk, and that's just part of living in the world that we live in. And I think it's absolutely I don't disagree with the sentiment to a certain degree. We do have to keep living our lives. The point is we could decrease our risk, though, by doing some simple things like being immunized and wearing masks at appropriate times. It will not prevent everyone from getting COVID, but it will decrease the incidence significantly.
Yeah, I mean, if people got COVID and every single person needed to stay home, we wouldn't care about COVID, right? It wouldn't matter. It wouldn't really impact the community. But it's severely impacting at least the healthcare community, because now it makes it really hard to take care of the non-COVID patients with heart disease and heart attacks and strokes and diabetic ketoacidosis and pulmonary dysfunction and kidney disorders and things that always came to the hospital. But now we're having to essentially water down our resources because so many COVID patients are in the hospital, consuming so many resources, taking so long. So frankly, I think people are selfish if they only think about themselves and not think about the community that they live in, because it actually, your choices impacts other people, including the community that you live in.
Okay. I do have a last couple of questions. I know we told you we'd keep you a half hour and we're at it. So if you don't mind, just 5-7 more minutes. One that does come up so much, and someone asked it. So again, I apologize for this question in some ways, but do masks work? Because a lot of people don't believe masks do anything.
So I think when we ask questions about does such and such work, we have to always remember that almost nothing in this world is 100%, right? So wearing a mask will guarantee that you don't get COVID? Absolutely not. But there are multiple studies showing that we wear masks for different reasons. One of them is if we have COVID, we wear that for what we call source control, which means that by wearing a mask, if I actually have the virus and I don't realize it, I decrease the number of viral particles that are in the air and make it less likely that other people will get it. We also can wear masks to prevent or decrease the risk of inhaling those viral particles or decreasing the load of viral particles that we get. So really all of these things are cumulative, one on top of the other. And we use a multiple of strategies to decrease our risk because nothing is absolutely perfect.
Perfect. Thank you. All right. So let's say an individual has COVID. What's the treatment?
So there are a lot of treatments. So if somebody is sick enough to be hospitalized, there are a multitude of medical treatments, medications, high flow nasal cannula, heated oxygen. If they get super sick, they get intubated, put on a ventilator, they get paralyzed, sedated, antibiotics, antiviral agents, they get prone, flipped on their belly, sometimes for a period of several weeks. And then if eventually we do a tracheostomy, a surgical feeding tube, and get them off to a rehab or a nursing home. That's basically, the whole spectrum of hospital-based care. And sometimes it requires very little of that, and sometimes it requires every single piece of what I just said.
Okay. Next question is, can you educate us, explain what are monoclonal antibodies? Does Swedes do this? What's your stance on it? What are they?
Sure. So we do provide monoclonal antibody therapy for COVID-19. Monoclonal antibodies, our bodies naturally make antibodies to fight all kinds of infections. Monoclonal antibodies are antibodies that are made in a laboratory to fight specific infections. And monoclonal antibodies against COVID-19 bind to what's called the spike protein of COVID-19, the COVID-19 virus, which inhibits that virus from being able to attach to and attack cells. And monoclonal antibody therapy for COVID-19 is available to individuals who are at least 12 years old and 88 pounds in weight, who have recently tested positive for COVID-19. And they need to be treated within 10 days, actually as soon as possible after diagnosis, to have the best effect. And it's generally given to people who are at high risk for developing severe COVID-19, but have not yet been admitted to a hospital. Because by the time you're sick enough to be admitted to the hospital, the way antibodies work, they just aren't going to be able to do that much for you. Okay. So if you test positive, and when we say high risk, you remember just a few minutes ago, maybe you recall Dr. Cole mentioning that if you're taking high blood pressure medication, you're considered at high risk. If you're overweight, you're considered at high risk. So almost anybody who tests positive at a minimum should be talking to their doctor about whether or not monoclonal antibodies would be an option for them. When you test positive, your risk of being hospitalized is probably somewhere between about 5 or 10%. And that really depends on how young you are and otherwise healthy you are, and probably just dumb luck in some cases. But receiving monoclonal antibody treatment cuts your risk in about half. So probably anywhere, risk goes down from 5 to 10 to maybe 2.5 to 5. Those are very rough numbers, but it is an effective treatment for reducing the risk of being hospitalized with COVID-19.
All right. So people there's a whole host of folks commenting. Some are saying that, well, we don't treat anyone before they're hospitalized, and that's really foolish. If we didn't treat pneumonia until you got hospitalized, that'd be foolish, blah, blah, blah. So there are treatments that are being done prior to someone being hospitalized.
Yeah, monoclonal antibody therapy, we don't use it at all in the hospital because, again, by the time you're sick enough to need it in the hospital, it has been shown that it's not very helpful. There are the FDA is in the process of approving or providing emergency use authorization for 2 oral antiviral medications, molnupiravir and Paxlovid, which hopefully will be available. The molnupiravir maybe before the end of this year. These would be medications also that would be given early in the course of the disease to people who have very mild disease that would prevent it from progressing to severe disease. We don't know a lot about it. It's probably going to have a very limited supply when it first comes out, but hopefully within the next 1 to 2 months, we'll be seeing some of that as well.
Wonderful. All right. Got 3 last questions for you both. So thanks again for all your time. we keep hearing of it. It seems like every couple of weeks there's a new variant. What do we know about the newest variants?
So the Omicron variant is, it has about 50 mutations on the spike protein. And that is a little bit of a problem because our immune system and the vaccinations they're effective against the spike protein. However, so what we know is it's highly infective, but what little information we do know suggests that it's not as severe. It's a little bit of a shorter lasting disease. It's in Illinois, by the way. I just read today it's in Illinois. So, I mean, it's just gonna be a matter of time when it's everywhere, but hopefully it's not going to have as big of an impact because if it's just mild disease and most people don't need hospitalization, then that's
there's a lot we don't know at this point. It's still pretty new. The first case was identified in Illinois 2 days ago, and it actually occurred in an individual who was fully vaccinated and had a booster.
So if let's say you're someone, I'll just use myself. I got the vaccines, did Pfizer, I believe, 1 and 2, and then my third booster, I believe, was Moderna. Does that make me less receptive of getting this new variant, or?
We think so. We don't know the answer to that yet. The only studies that have been done so far are really what we call in vitro studies, meaning they take antibodies and mix them up in a petri dish, more or less. So we really don't know how well the vaccines will work in actual human beings in an actual community. We're learning that. There's reason to think that they are going to be better than not being vaccinated. But that's a lot. Those are things that we'll kind of learn over the next weeks to months or so.
Okay.
Yeah, I'm not worried so much about Omicron yet. I'm still really worried about Delta because that's what's really crushing the community.
Great point. Thank you. And you are seeing the Delta a lot in the hospital and the ICUs. Is that what the impression I'm getting, Dr. Cole?
Yeah. So I think that one thing that's important for people to know is that because it doesn't change the treatment depending on the variant that you have, we don't routinely test people for which variant they have. The state has the Illinois Department of Public Health has a program whereby we send them a certain percentage of our positive tests, and they do the genomic testing to figure out which variants are circulating in the community. But because it doesn't really change the treatment that we offer to people, we don't test everybody to find out which variant they have.
Okay. And I lied. Now I just have one more question for my own self. I hear a lot of people, well, I got vaccinated or my uncle got vaccinated and boosted and still got sick. So see, it doesn't work. What do you say to that? It was
never touted as being 100% perfect. I think Pfizer and Moderna both said it's about 90 to 95% effective. And there are some people who just, their immune system is just not that robust and it doesn't mount a good immune response. So
there's also, by the way, doctor, there's also some people who don't like listening to all the facts and like to pick which pieces, so they forget that it was never touted as 100%. So thank you for saying that.
I think the other thing that, and people, I've seen comments, not yet on here, but I'm sure they'll come, about they don't like this analogy. But I go back to the seatbelt analogy, right? I mean, do people die in auto accidents even when they're wearing their seatbelt? Absolutely, they do. Do you have a lower risk of dying in an automobile accident if you wear a seatbelt? Yes, you do. So it's the same kind of thing. We can't just take any one case and say, see, that proves it doesn't work.
Yeah. So, all right, I'm 10 minutes over. Last two questions. I'm going to combine them. Would love both of your thoughts on this. One, will we just always have COVID in our community and in the world? And two, what's the last thing you want to leave today's conversation getting out or reaffirming, however you want to phrase that?
I don't think we have to always have COVID in the community. I know a lot of people say that, but that the only reason that we may always have COVID is because people are going to refuse to be vaccinated. The virus cannot exist. It cannot multiply unless there is a host in which it can multiply. So if in theory everybody got vaccinated, then the virus would have very few human hosts in which to find and multiply, and it actually could burn itself out.
And I would hope for that too. I suspect it will be around to some degree for a while. But, we have eliminated viral diseases in the United States and in the world. Smallpox is no longer a disease that we see, especially not in the United States. Polio is extremely rare in the United States. Unfortunately, it's still common in other places. So it is possible, but it takes persistent effort in things like not just developing new treatments, but in these preventive things like vaccination. So that's the thing that I would certainly want to leave everyone with is we absolutely strongly encourage people to be vaccinated, to become fully vaccinated. If you have been vaccinated and you're eligible for a booster, I would encourage you to go and get that booster. There is nothing that will decrease your risk of having severe illness from COVID more than being vaccinated.
And finally, I don't live in fear. I've been vaccinated twice. I've been boosted. I wear a mask all the time. I'm a surgeon. I've worn a mask all the time for 30 years. But I'm smart and I'm safe about who I hang around and what I do. But I do not live in fear, and I feel like I have a pretty darn good life.
Well, I just so appreciate both of you, again, taking time today, but all the work that you're doing. And above that work, getting out, sharing the information to some of us who don't have medical degrees. I know lots of people went to school for 7 years and still don't have medical degrees, but appreciate the work that you do. And again, please share with your staff my sincere appreciation and all of Rockford's sincere appreciation for the hard work that they do every single day. So thank you, and appreciate you taking the time. And to all the listeners, appreciate you taking the time to join us today, and hopefully it was beneficial to you.